Who is Dr. Ovilash? Hello, can you please let me know who is Dr. Ovilash?
He's muted, I guess.
Yeah. He is a student in Hyderabad only.
Okay,
Oh,
I think
he left.
yes.
So he can join from that another
Delegate
delegate
list.
link. Yeah.
Yes,
Oh,
yes.
oh.
Okay,
There
so
are
we
two
are
links.
starting.
Two links, such faculty link and this link. I think okay. You mute yourself. That would be sufficient.
Okay. So yeah. So,
Yeah.
start.
So, good afternoon and welcome to one and all. I'm Sreushi, the assigned moderator from Clanet. Clanet is India's most trusted and widely used digital platform with multiple enriching services for doctors. Clanet is very proud to be a part as a digital partner for this event organized by Indian Pharmacology Society, West Bengal branch, and today's session is all about online lecture session. So, let's begin today's session, for which I would like to invite Dr. Shambo sir to take over. Kindly proceed with the talk, sir. Over to you.
Thank you, Clarnet, for helping us out to provide this online platform. And we are really delighted to have with us today our President, Sir, Professor Tapon Mondal, who is President of Indian Pharmacological Society, West Bengal branch. And also he is currently Vice President of Indian Pharmacological Society, Central branch. So welcome, sir. Also with us today, we have Professor Sneha Ambwani. Madam is currently Professor and Head at Department of Pharmacology at AIIMS, Jodhpur. So we are really privileged to have you, Madam, with us today. And also Dr. Sharmila Nath, currently Joint Secretary at Indian Pharmacological Society, West Bengal branch, and also she is Associate Professor at Department of Pharmacology at Medical College, Kolkata. So she will also join as chairperson for this particular session. And we have with us today none other than Dr. B. Kalakumar, who needs no introduction amongst the fraternity, pharmacology fraternity. Sir is currently the General Secretary of Indian Pharmacological Society. So welcome, sir. So first of all, may I invite our President, Professor Tapon Mondal, sir, to say a couple of words before we are handing over to the chairpersons.
Thank you, Shambo. So heartiest welcome to all the participants, particularly the chairperson of this session. And we are also happy that today's speaker, Professor B. Kalakumar, Secretary General, Indian Pharmacological Society. Welcome, sir, because you have taken our invitation to present this very, very important topic, which is needed for biomedical research persons. So already Dr. Shambo has told about you, so there is no need of any introduction of Dr. B. Kalakumar. He is the devoted person in our pharmacological society. He was several times act as treasurer of the society, and he has done successfully the activity of the treasurer during that period. Now he is the Secretary General. He has also completed his tenure. So I will welcome again Professor Kalakumar. Now I will also welcome the chairpersons. So I will hand over the mic to our chairpersons to conduct this session.
Good afternoon, all. First of all, I thanks Dr. Samajdar who invite me for this session. This important session on. And before we start, as you know that Dr. B. Kalakumar is going to present a session on animal models for screening and validation of anti-inflammatory property of an investigational molecule. And as you know, that this topic is very current, and all our participants who are there to attend this seminar, they will be definitely benefited by his talk. So now I invite Sir to present his talk.
Thank you, madam. Thank you very much for sharing the session and also for the kind words that you have spoken about me. I think, Shambo, am I audible? So just check if everything is
Yes, sir,
okay.
you are audible,
Yes,
but I
yes,
think
okay.
Dr. Ohilash need to be muted. So can you please ask?
Yeah. If at all, if there is any, yeah. So you want my video to be on, or it can be off?
On. It will be better if you on your video, sir.
Yeah. Okay.
Now
So
we can see you also, sir, and your screen is well visible, and we can hear you properly also.
yeah, but I think it is stuck. Yes. Now, inflammation, a sequel of injury. Injury could be due to mechanical, thermal, even bacterial, viral, whatever is the injury, inflammation follows. Inflammation follows with the sole aim that it could attract inflammatory cells and as well as the mediators, and then the process of healing starts over. So the cardinal signs of inflammation would be, as we all know, that it's dolor, rubor, tumor, calor, and functional loss of function. So whenever there is inflammation, you find that there is pain, redness, swelling, and heat. Now, coming to swelling, why there should be swelling? Swelling because as soon as there is injury, you find that there is a little bit of swelling. This swelling is due to the extra the gap between endothelial cells increasing, and then the fluid that is supposed to be in the vessels coming out into the tissue. And there is redness because there is capillary dilation, and there is also pain due to release of substances, inflammatory mediators, which increases the sensitivity of the nerve endings. And there is also heat due to the inflammatory process taking place over there. And loss of function, it all depends upon the type of injury that we have. Coming to this particular slide, I have this slide to show you that just one minute. Yeah, to show you that this is what happens in inflammation. If you just look at my cursor, so you have the phospholipid that is which is acted upon by phospholipase A2 and also phospholipase C. And now this arachidonic acid is further acted upon by cyclooxygenase, lipoxygenase, resulting in the formation of prostaglandins and leukotrienes. And these prostaglandins and leukotrienes, they are responsible for inflammation. And we also have the PLA2 responsible for the formation of platelet activation factor. This also causes inflammation. And you have free radicals which also contribute to inflammation. Apart from free radicals, we have cytokines, transcription factors, and protein kinases, hydrolytic and hydrolytic proteases, and also enzymes which do cause inflammation. And apart from this one, the PLC, the phospholipase C, is responsible for formation of PIP2, and this PIP2 in turn forms DAG and DAG or IP3, and DAG in turn stimulates PKC, and this PKC in turn results in inflammation. So these are the various target. So why we have discussed the mechanism of inflammation is that if we are thorough with the mechanism of inflammation, and then we can just try to block or come out with drugs, specific drugs. For example, we say that COX is actively responsible for the formation of prostaglandins, the most common pathway as far as inflammation is concerned. So when it comes to cyclooxygenase, if we and we have COX-1 and COX-2 inhibitors, rafecoxib, valdecoxib, which are specific COX-2 inhibitor, and in veterinary science we have meloxicam, right? So so likewise, if we can come out with with those drugs which can inhibit these enzymes, or if we can really arrest the production of free radicals through antioxidant, or PKC inhibitors or LOX inhibitors, um, LOX inhibitors, then I think then that would be the best way to come out with anti-inflammatory drugs. And then, well, if you just look at this particular slide, you have the carrageenan induced pyoedema model, the most widely used model. And here in the first phase, it causes the release of histamine, 5-hydroxytryptamine, kinine, and platelet activating factor. And in the second phase, it is responsible for the production of prostaglandins, bradykinin, and also lysosomal rupture. So this histamine, we know that histamine and 5-HT, they are vasodilators. So they increase vascular permeability, and when they increase permeability, as we have discussed earlier, that results in the formation of the formation of the edematous fluid over the particular area where the injury is. So, so we have histamine and 5-HT kinine and PAF in the first phase, and then this this can be also studied with the carrageenan-induced pyoedema model, can be further correlated with dextran-induced pyoedema, where 5-HT and histamine are released, and if these two they coincide with each other, then we can say that our experimental design is fine, right? And then you also have the second phase, that is prostaglandins, bradykinin, and lysosomes. Here, the same thing can be also studied with formaldehyde-induced pyoedema, where you have the early phase and the late phase. In formaldehyde-induced pyoedema, in the early phase, you have bradykinin and substance P that are released, and in the late phase, you have histamine and 5-HT and prostaglandins that are released. If you just observe this, it's exactly opposite of what carrageenan has done. Carrageenan in the initial stages, it has released histamine and 5-HT, whereas formaldehyde in the late phase, it has released histamine and 5-HT. So that's how you find that bradykinin, which is a known vasodilator, induces pyoedema. And pyoedema is easily measurable, and we have a good number of instruments to assess the pyoedema. We have the plethysmometer and this being a non-invasive procedure, it's very much easy. And coming to the arachidonic acid-induced pyoedema, under the same heading, you have croton oil-induced ear inflammation, which also acts through the release of prostaglandins, that is arachidonic acid metabolites. And then you have TPA-induced ear inflammation. Here it is, TPA is nothing but the active moiety in the croton oil. And here you have two, that is by inducing ear inflammation with TPA, you can have a more potent arachidonic COX inhibitor, or a less potent arachidonic LOX inhibitor. And then we have leukotriene before induced pyoedema. And then we're coming to just 1 minute. Yeah. And coming to the acute inflammation. Now, under inflammation, you have acute, subacute, and chronic inflammation. I'll try to I'll try to race out so that we do not fall short of time. I also have some slides on pain. So the carrageenan induced pyoedema is a distinctive model with greater reproducibility, and it is the most extensively used model for as far as anti-inflammatory the drugs are concerned. So one important point with carrageenan is that it is devoid of any visible systemic effects. So even if you are going to give it if you are going to inject into the rat paw, that is not going to be absorbed, and it is not going to cause systemic effects, but certainly it is going to cause the inflammation which is desired. So the sulfated sugars present carrageenan, they are responsible for the activation of complement system, and then the presence of the inflammatory mediators at the site where you have injected your carrageenan. So it also stimulates phospholipase A2 and is responsible for the early phase of inflammation. And once the early phase starts and these cytotoxic effects, they progress to the inflammation. So carrageenan, it dilates postcapillary venules, and there is exudation of inflammatory fluid, cells, and releases several pro-inflammatory mediators. So these events represent the early exudative inflammatory phase. And then you have this model is typically linked with the activation of the COX pathway. So when we say COX pathway, glucocorticoids and prostaglandin antagonists, that is glucocorticoids and NSAIDs, they can be studied with this particular model because they are going to inhibit this COX pathway. And the edema that is developed with carrageenan is said to be biphasic, and the first phase you find that there are release of acute phase mediators, that is serotonin and histamine and prostaglandins in the second phase. So this is a picture of the rat paw, and then this is where we have to inject just after the foot pad. You need to inject it here, and once we inject it here, within 3 hours you find the effect. And this is a picture of digital plethysmometer, and this is water cell, the transducer, and this is the water reservoir, and this is connected to a digital display. And here the rat paw. Yeah. So we need to make we need to just mark. We need to just mark that we are going to dip up to this level, and we need to just dip up to that level only. Even in control as well as treatment group, we need to have a clear-cut demarcation where we can where we are not going to dip it more, and where we are going to have a distinctive mark, right? And if you just see here, this is one this is one photograph where you find that there is lot of edema, and now the next one would be the histamine or 5-HT induced paw edema. Histamine and 5-HT, they are also injected into the rat paw, so that they are known mediators of inflammation. And if you want to study those substances which are responsible for the release of histamine or 5-HT and which antagonize these two substances, then we go for this histamine or 5-HT. So these two being vasodilators, they promote vascular permeability, and along with prostaglandins, they induce inflammation. And subplantar administration of histamine causes the outflow of fluid and the plasma into the extracellular spaces, and it also increases the flow of lymph, and which adds to edema. And histamine releases neuropeptides and prostaglandins, leading to hyperalgesia and inflammation. And we have bradykinin-induced paw edema. This is partly mediated by the prostaglandins, and there is stimulation of phospholipase activity by bradykinin, which promotes the biosynthesis of prostaglandins. And indomethacin or related NSAIDs, whichever are going to inhibit the synthesis of prostaglandins, they are going to show a decrease in bradykinin-induced paw edema, right? And it has also been found out that incubation of human endothelial cell with bradykinin, it releases arachidonic acid metabolites. So this has to say that that the bradykinin-induced paw edema is ultimately a result of the prostaglandin synthesis. And we have dextran-induced paw edema, and this is also increases the vascular permeability, and this leads to rapid and transient development of edema, and it activates kinin. And there is also release of mediators like histamine and 5-HT. And then we have this lipopolysaccharide induced paw edema. And here, in case of lipopolysaccharide induced paw edema, if you want to study the role of cytokines in inflammation, then we go for this lipopolysaccharides induced edema. And here you find that it increases TNF alpha, IL-1 beta expression, and also myeloperoxidase activity in the mouse paw. And this lipopolysaccharide it assists in the identification of drugs that are effective against TNF alpha mediated inflammation. So everywhere, in the first instance, it was non-specific, but when it came to histamine, 5-hydroxytryptamine and bradykinin, it was specific for those agents. And also when it comes to lipopolysaccharide, it's all about the complement system activation, right? So if the complement system, the cytokine system has to be studied, the role of cytokines in inflammation have to be studied, then one can go for lipopolysaccharide induced edema. All right. And yeah, and then you have arachidonic acid induced ear edema. And here in this, this is to identify those compounds which are used in the treatment of inflammatory diseases of the skin, and also to assess the anti-inflammatory potential of synthetic compounds and herbal extracts. Today, we have many researchers working in this particular area of natural products as anti-inflammatory and analgesic agents. And then you have these prostaglandin E2, leukotriene C4, LTC4, and thromboxanes, which are responsible for the ear edema induced by arachidonic acid. And here, when you look at the inflammation with arachidonic acid, you find that there is intense erythema, accumulation of neutrophils, and also increased IL-1 beta expression. Actually, these prostaglandins, that is E2 and LTC4 thromboxanes, they are said to cause degranulation of the mast cell, and they cause release of histamine. Therefore, the anti-inflammatory activity demonstrated by compounds in this particular model, they are also said to have antihistaminic and antioxidant property. So now we were talking only about prostaglandins, COX and LOX, but here we have antihistaminic and antioxidant property of the compounds can also be assessed. If you just look at this is a particular compound, WT25. It's a herbal compound, and then you have this particular model, and this is control, and this is the treated group. Now you can see that there is edema of the ear. And then you have proton oil or a TPA-induced ear edema. As I mentioned before, TPA is nothing but the irritant principle that is present in proton oil. When we say proton oil, it is same as the croton plant that we have as for our in our garden, and also as indoor decoration. So here we assess the anti-inflammatory activity of steroidal and non-steroidal anti-inflammatory drugs. Now, slowly from non-specific, we have come to histamine and bradykinin and arachidonic acid metabolites, and also cytokine-induced edema through lipopolysaccharide induction. And now we have the steroidal activity being assessed. Now, all these, we are still under acute inflammation only. And steroidal activity, the steroidal activity of the natural compound, if it can be assessed, it has to be assessed through proton oil. This particular model is also used for the appraisal of systemic and local anti-inflammatory compounds. And you have the signs of this one are vasodilation from vascular permeability, neutrophil influx, and synthesis of eicosanoids, and liberation of serotonin and histamine. And PGI2 and LTB4, prostaglandin I2 and leukotriene B4, they augment the vascular permeability. And the pro-inflammatory effects of this particular irritant principle, that is TPA, they are stimulated by protein kinase C, and which in turn activates mitogen activated protein kinases and also phospholipase A2, right? The COX, LOX, and PLA inhibitors and corticoids, they have the capability to suppress the inflammation through that is brought about by TPA. So here, one thing I would like to stress is that now the word corticosteroids has come. Corticoids has come. Corticosteroids, no doubt, they also inhibit prostaglandin. They also inhibit the COX-induced prostaglandin synthesis. That's one aspect, and this is the next aspect. That is, they specifically they can be assessed through this croton oil-induced ear edema. And another model that is available is oxazolone induced ear edema. And here, this particular model is used to study the allergen induced delayed type hypersensitivity. Here you find that the skin sensation is produced by CD8 plus T lymphocytes, and the topical application of this oxazolone, it leads to elevated prostaglandins and leukotrienes, and it also enhances the NOS2 expression in keratinocytes, nitric oxide synthase 2 expression in keratinocytes. So repeated oxazolone application to the ear of experimental animal induces chronic contact dermatitis also. So with continued ear swelling, noticeable inflammation, cell infiltration, and prominent epidermal hyperplasia. Additionally, there is a marked increase in interferon gamma level and minimal alterations in the IL-4 level. So it increases the keratinocyte proliferation and causes epidermal thickening. So oxazolone-induced ear edema, especially related to the oxazolone being an allergen, it is for the initiation of delayed type of hypersensitivity. And now coming to acetic acid or compound 4880 induced vascular permeability. This is to study the inhibitory activity of drugs against increased vascular permeability, right? And here, this compound 48/80 is responsible for mast cell degranulation, and also it is a potent actor of histamine release, prostaglandins, and leukotrienes. So it increases vascular permeability through dilation of arterioles and venules. So, and the plasma proteins and fluids are extravasated, and that results in edema. Here, one aspect is that the increased vascular permeability can be assessed by injecting Evans blue dye at the injected site. So then you can have a clear picture of the vascular permeability. So here, first acetic acid is injected, and then this is followed by Evans blue, and then you find that the Evans blue particles they would be seen alongside the blood vasculature, saying that it has increased the vascular permeability. The endothelial cell gap is increased, and once it is increased, you find that there is escape of this Evans blue. And then one more acute model that is extensively used, especially during corona. We have used this particular model, pleurisy model, and this is established experimental model of acute inflammation. Here you can have the exudate, and then you can also quantify the proteins, quantify quantify the inflammatory cells, and also you can conduct inhibition of leukocyte migration. So with this particular pleurisy model. So during corona, what we did is we injected LPS into sorry, we did not inject, but intratracheally we have administered. It's not that we opened the trachea, but what we did was we have, of course, this is a established model. What we have done is we have anesthetized the animal, and then we have placed the animal on an inclined board at a 45 degrees angle, and then the tongue of the animal is pulled out, and then with the help of a micropipette, the desired volume is instilled in the posterior pharyngeal region. So, and you take the help of the palate, and then through the palate you just drop this particular fluid into the posterior part of the pharynx. And then if the animal has if your drug has entered, or if your fluid, if the LPS or the drug or whatever it is, if it has entered into the trachea, then there would be a sound glut, glut, glut. So this particular one has to administer, and then one has to lend his ear to assess this sound, this particular glut, glut sound. So that gives a confirmation that yes, this has been this has been this has been rightly administered, and that it has entered into the trachea. And once into the trachea and through the bronchi, it would affect the lungs. And then if you want to study the effect of the anti-inflammatory effect of certain substances, you can. And after the distinct time of 24 hours or 48 hours, you need to sacrifice the animal, and then with the help of with the help of a butterfly needle and a tube, you need to collect the bronchoalveolar lavage fluid. So this fluid would contain the total proteins, the inflammatory mediators, and everything. So you can quantify here. Whereas in all other cases, it's only a quantitative this one, and we go for indirect estimation of the plasma biomarkers. But here you can directly collect the bronchoalveolar lavage fluid and then estimate the proteins and whatever you want to. So this is one of the wonderful model, and there is Journal of Visual Experimentation, Journal of JOVE, J small o, capital V, and capital E. So this is one of the wonderful journals, video journals, where they give you the protocol. They also give you a beautiful video on how a particular animal model can be established, and this would really help our medical pharmacologists and also other pharmacology scholars to develop an animal model. So this, but the only thing is that you need to have subscription. But there are certain institutions which have already have some central institutes and some prestigious institutes. They do have the subscription. The subscription is about 6 lakhs per annum, I suppose. So you can make the best use of it. But this is one of the best models that I have seen, that it is that it was useful during COVID time. Or the only one problem is that you need to sacrifice the animals. If you want to collect the BALF, that is bronchoalveolar lavage fluid, you need to sacrifice the animals. That's the only one disadvantage that I found. But otherwise, it's a very beautiful model as far as acute inflammation of the lungs is concerned, right? And actually, if you just look at the B part of this picture, here it's oral gavage, but instead of that, and here the animal is not anesthetized. But what you have to do is you will have to put your micropipette here, because you are not targeting the GI tract, but you are targeting the respiratory tract. So you need to keep it you need to just keep it. You need to just place your pipette, the tip of the pipette, into the posterior pharynx and as I told you, you need to pull out the tongue, and this is only 90 degrees. It's perpendicular. No, it has to be on an inclined board of 45 degrees. So that would be of good use. And then you have subacute inflammation, that is granuloma pouch model. And still now we were talking about acute inflammation, and now we have subacute inflammation, and then you have the granuloma pouch model. All that we have to do is the irritant substance is injected into the subcutaneous air pouch, and it produces proliferation of granulation tissue, right? And this subsequently I'll tell you what this granulation tissue is. So and the granulation tissue, it comprises of endothelial cells and fibroblasts. And administration of irritant substance, it causes macrophage. It causes macrophage and polymorphonuclear leukocyte infiltration. In this model, there is a possibility of exposure of growing tissue to the carcinogenic and mutagenic substances, right? And then we have the chronic inflammation, that is cotton pellet induced granuloma. So till now, we were talking about acute inflammation, we talked about subacute inflammation, and now we're talking about chronic inflammation model. I'm only talking about animation, about the animal model. My interest of just talking only about the animal models and just trying to share my experience is that I wanted that the medical pharmacologists, they should once again uh, return to experimental pharmacology. Of course, I'm not the undermining clinical pharmacology or its importance, but if our medical fraternity, if they can really come into the experimental pharmacology, I think that would be really, really good. That's what I was sharing with Shambo many a time. And as part of this one, we have conducted one meeting. When I asked my medical friends, they said that, oh, the CPCC, this animal experimentation regulatory body, is not friendly. So we called the joint secretary over to Kolkata. We had one-day workshop, and then we had a one-to-one discussion with him, and as to how best we can improve experimental pharmacology in medicine. Right. Now coming back to the subject, chronic inflammation, cotton pellet induced granuloma is number one. So this is represented by monocyte infiltration, fibroblast proliferation, angiogenesis, and exudation. Right. And here you have transudative and proliferative elements. And both the elements can be evaluated through this model. That's the beauty of this model. First is transudation, and then you also have those elements which proliferate. Granulomatous tissue formation is the hallmark of this particular model. And now, what does granulation tissue contain? It contains the macrophages, neutrophils, fibroblasts, and small. As we said that there is angiogenesis, you find that there are small blood vessels and highly vascular reddish mass, and with this reddish mass is called as granulation tissue, right? And the fluid absorbed by the pellet, that is the moist weight, is that gives you the granuloma. And the moist and dry weight of cotton pellet is linked with the transudate, right? And so the moist weight gives you the transudate, and the dry weight gives you the granulomatous tissue formation. And corticosteroids, they are said to inhibit the inflammation at the proliferative phase. As I told you that we can study the transudative and the proliferative phase. So corticosteroids, they are going to inhibit at the proliferative phase, right? And these are the cotton balls that have been placed inside, and this is the granulomatous tissue that has formed. So this is how we can have this chronic inflammation model, that is granuloma model. And then we have formalin induced spa edema. And when you inject formalin, it has close resemblance with the human arthritis. And here the inflammation is biphasic, that is, it is neurogenic and also the inflammatory phase. The neurogenic phase, which is related to bradykinin and substance P, and whereas the inflammatory phase, it involves the inflammatory mediators such as histamine, 5-HT, prostaglandins, and bradykinin. So CNS acting drugs, they act on the neurogenic phase, whereas NSAIDs and corticosteroids, they act on the inflammatory phase. So you can you have the richness of able to look at both the phases, that is the neurogenic phase and as well as the inflammatory phase. Inflammatory phase can be taken care of by NSAIDs and corticosteroids. So if a drug is able to inhibit both, or if your test drug or if your test candidate is able to inhibit both, then you say that, oh, it is anti-inflammatory, both related to neurogenic as well as the inflammatory phase. If it is able to just block the inflammatory phase, it may have NSAID or corticosteroid-like action, or if it has CNS CNS-like action, then you can say that it is related to opioid. And here I would like to draw your attention that during COVID time, we have proposed one medical hypothesis that the mild electric shock can result in can help the person to have a better healing during COVID. So we were questioned about the basis of it. And we have found out that these acupuncture, acupressure, and also this electric shock, mild electric shock, they are all going to release enkephalins and endorphins. And we know that enkephalins and endorphins, they increase the immunity. They don't decrease the immunity, but they increase the immunity. And that's how they are going to help the patient in rapid recovery. And then we have complete fluence adjuvant induced arthritis, and this is also a chronic form of inflammation, and this is extensively used, like carrageenan induced pyedema. Here CFA induced arthritis is extensively used. So here you have inflammation along with synovial hyperplasia, and there would be massive leukocyte infiltration, and also the IL-1 beta and TNF alpha is going to increase. There would be production of radical oxygen species, cartilage and bone destruction, and along with swelling and deformation. And CFA injection into the footpad of a rat, it causes swelling of periarticular tissue like ligaments and joint capsules, right? And now here one advantage is that ipsilateral, that is ipsilateral means the path that is injected, and contralateral, that is the path that is non-injected. Both of them, you can go for antioxidant estimation, you can go for visual arthritis scoring, nitrite content determination, hematological and biochemical evaluations, along with radiological and histopathological studies to assist in elucidating the probable mechanisms. So in one animal, you have the luxury of having both, that is one leg serves as control and the other leg serves as a treatment. And then you can assess which one would be more better. So that's all regarding inflammation. I think it's already 3:45. So can I share some slides about pain also, or shall I just refrain here? Shambo?
You can show some important slides, sir, if
Slides,
you want.
Yes. So this is one one slide where we have this chronic constriction injury model, that is a diabetic neuropathy model, and here this is the sciatic nerve. Here, this is the sciatic nerve with the loosely tied thread. So this is going to cause edema in the spaces, and then that's going to cause that's going to mimic diabetic neuropathy. And of course, you also have spontaneous modal assays for that. That is Goto Kakizaki rat develop. The rats, they develop type 2 diabetic mellitus with neuropathy. So you need not go for CCI. But if you don't have that particular rat model, which is quite costly and which is not easily available, then you can go for the sciatic nerve. And we know that the sciatic nerve, it runs along the course of the femur. You have the femur bone, and the posterior, just posterior to the femur bone, you find that the sciatic nerve runs. And then you can just take it out and then expose that, and then have this ligation, right? And this is the behavioral a slide showing the behavior of these rodents, and this is one particular posture that is shown by the animal whenever it is sick, and this is one that shows that the animal is suffering from pain. But actually, this is how it is if you just look at the neutral and the relaxed positions, you find that the animal is just just uh, uh, normal. And you can also see when it is happy. When it would be happy, whenever the scientist or the experimenter goes near the animal looks at the face of the scientist. We think that maybe the animal is not in a does not recognize and all that. No, it recognizes the attender. It recognizes the cue, because these animals, they are all they can't store their food grains. Hence, they need to depend on their cognitive ability. So they have more cognitive ability, cognition, recognition. So this is what I would say. Cognition is the first picture. Recognition is just retrieval of the first picture. So you have this you have this posture, and these are some of behavior, some of the behavioral figures of the animal. So hind paw, generally we don't target the front paw, we target the hind paw. And this is how it starts licking, if at all, if there is a thermal, mechanical, or cold or cold sensations that are going to disturb the animal. And then you have this orbital tightening. This is the orbit, and if it is in pain, then there will be orbital tightening. And then you have nose or cheek flattening, and then you have the ear changes, and then you also have the whisker changes. So orbit, nose or cheek, ear, and whiskers, these are going to help us in determining whether the animal is suffering with pain or there is absence of pain. And whenever we treat whenever we treat with a drug that is 50% effective, then instead of normal, it may fall in this category, that is 0, 1, and 2. Instead of it may not fall under 2 because it has only 50% efficacy. It may fall under 1. The score would be 1. Once again, action unit: eyes, nose, ears, and whiskers. The distance between the ears, the nose, the eyes, and also the whiskers. Yeah. So this is one slide which shows you the analytic activity of drugs by tail flip method. So if you find that, of course, in inflammation, here I am talking about pain. I have some slides about pain. I thought that would be interesting to you, right? So you have this tail flip method, and then the tail is placed here, and as soon as the temperature is increased, and at a particular point, the animal lifts its tail, and the point at the temperature and the time, both of them, they can be captured digitally. So that's how we what happened yeah, that's how we can assess the pain in the animal. And then these are worn-free hairs, and this is electronic worn-free hair with a digital display. This worn-free here is nothing but just to have just to know the threshold of pain. And it would be graded. It would be graded from green, blue, dark blue, to orange, and to red. And as it increases, as the color intensity increases, you find that the diameter of the hair would be more. And initially, initially normal, in case of normal skin, or in case of analgesic, in case of analgesic drugs, they can bear they can bear the stimulation of the by these worn-free hairs. But if it is if it is to be sensitive, like allodynia, then it responds with a cry or withdrawal with the green worn-free hairs. And the same thing is applied over here also. Here also you find that it is electronic worn-free hair, It gives you a graph of force and time, how much force has been applied and what is the time of latency, means how much, how long the animal was able to withstand the force that you have applied, right? And this is regarding the mechanical pain, the same thing, the same one-free hairs. The animal is placed on a mesh, and then we apply this one-free hair, and this is the electronic one-free hair. And this is Randall Celito apparatus. You are able to see this point, the sharp point, right? And this is connected to a digital display where the pressure is known. And here, this Randall Celito, it gives you a good indication of the sensitivity of the animal. And then you have the thermal test. The first one is tail flick. The B is the hot plate. And then the C is a Hargreaves test. And then you have the thermal probe. All of them, they would be assessing the thermal pain, right? And then you have the acetone and also ice cube or a ice that is placed on the animal, and then the withdrawal period, the withdrawal latency, or the emission of the emittance of a cry is noted. And here you have a two temperature preference. This one. So here, this is reference and this is test. And here in this one, we just see whether the animal is able, how long the animal is able to stand in this test area, right? So this is dolorimeter. Dolorimeter, it just looks at the edema that has been formed over there, and then based on this one, we can assess whether the particular drug is effective or not, the particular substance is effective or not. And this is the calibrated forceps. You are able to see this calibrated forceps and with the digital display. And this is the this is the rat paw, and then you can just put this calibrated forceps, and then we based on the ability to withstand the pressure that is being applied, we assess the activity of the drug. And once again, the Randall Celito apparatus, once again, with the digital display. And AD sort plate, I think most of us know. Of course, now with banning of animals for experimentation in the UG, which has to be there. Non-invasive, I think it has to be permitted, because until and unless one knows how to handle the animal, when he comes to the post graduation, he would not be in a position. Of course, he may learn it in a period of 10 days or 1 month. That's a different issue. But the very idea of handling animal in the UG, I think that should, in pharmacology, that should motivate people to come for PG. And this is a modified version of Hargreaves model. All that the animal is placed in that chamber, and then the stimulus is applied, and then it is measured as to how much time it has taken. It is connected to a digital display. And then you also have this pressure application measurement, PAM, and when you just apply pressure, then based on the efficacy of the herbal compound or the test compound, then the animal would withstand or emit the cry, right? Of course, you have conditioned place preference. If you permit me, I would take this analogy. When we were all children, we were accustomed to stay at home. We were very much happy to stay at home rather than school. So that is what is conditioned place preference. We were preferring home to school. And conditioned place avoidance, if you are not happy at school, if you don't have any friends, then that becomes conditioned place avoidance. So also here we condition the animal to we condition the animal, and then in one of the chambers we inject the drug, and then what we do is and then during the test time, we place the animal in we place the animal where there is a different type of injection or irritant. then animal automatically runs for the place where it was feeling that there was nothing. Means initially you injected only saline, but later on in the second chamber you injected an irritant. So the animal would prefer the chamber number 1 rather than chamber number 2. That's what we do. If you are not happy, we just avoid. That's what, as secretary, that's what I do. I just avoid certain mails and messages because I think that they're botheration. So also here the animal does the same, and the conditioned avoidance. That's what place escape avoidance paradigm. That's what I told you. Right. So this is I think we have come to the end of our presentation. Yeah, I don't know whether I have met your expectations or not, but I was expecting that medical pharmacologists would be there. So, but if my honest appeal to all the medical pharmacologists is that apart from clinical pharmacology, please concentrate on experimental pharmacology too, because you would be coming across first-hand cases of the adverse effects of drugs or the necessity of drug, right? And if you come out with that, I think we would together we would be helping the mankind. You would be doing it on human beings, we would be doing it in animals, and if the formulations and drug delivery systems, they could be taken care of by pharmacy. Thank you, Shambo, thank you, IPS West Bengal, the most active uh, local chapter as far as IPS is concerned. So thank you, Tapan sir, and Dr. Sneha madam. Thank you very much for being the chairperson. And I think right now you're very much into clinical pharmacology. I don't know whether you have really enjoyed my
No, sir.
lecture.
Of course, we are more into this simulation and all that, but all these animal experimentation still have their importance. And
yes, madam. Yes, that's what I wanted to stress.
That is,
yeah, that's what I wanted.
That is there. And thank you very much for a so nice talk.
Thank you, madam.
All the PG candidates who are there to attend this seminar, they must have enlightened with your presentation. And you discuss it in a very simple way. What are the different methods and how we can do it? Of course, right now we are having so much simulations, updated equipments, but still, as we say, old is gold. So
Yes.
these are the gold standard for evaluation or for screening of all the anti-inflammatory drugs. Thank you very much, sir. For
thank you, madam. Thank you, madam.
Very much, sir. I don't think there is any question in the chat box.
Ma'am, we have not received any questions, but
Okay.
we have received a comment that Dr. S. Selva Kumar, he's telling that good evening, sir, and your presentation was nice. Please send the slides, sir. Thank you. That's it.
Yeah, you please leave your email ID with Shreyasi, and I'll share the slides.
So may I also now request Dr. Sharmila Nath, another chairperson, if you have any comment, and also may I invite Dr. Ambwani madam, any comment on this issue?
Thank you, Dr. Shambo. Can I speak a few words? Actually, I was having a technical problem in my department, so I could not access the video that time. Sorry for being late.
No problem, no problem.
It was an extensive discussion and it was a very enlightening session. Sir, we are very much privileged to have you as a speaker in this session. Actually, we don't go through such extensively, we don't go into animal studies. We should, of course, we should have knowledge on all this. Of just one point, sir, I wanted to ask you whether all these things we are doing, we know the animal models are there, and how far do you think these animal models can be applied to the human medicine? Are there
Translation
any
pharmacology. Translation pharmacology is a question, madam. If we have humanized models, there are what are known as humanized models and spontaneous models. Generally, what we use is we we don't go for spontaneous models, or we don't go for humanized models. So there, in case of our studies, when it comes to translational pharmacology or translational research, there could be a problem. There could be one or two problems that could hinder the development of the drug into the clinical phase.
Thank you, sir. And of course, I know you are all working very hard to make this possible. And another thing was, sir, about the phytochemicals. They are again another group of drugs. Actually, what even if we don't prescribe, often the patients they use these
Yeah.
plant products, and particularly for chronic inflammatory diseases. Like I was a patient of, I'm actually a patient of rheumatoid arthritis. We often use different plant products. Now, what we do often in our studies, preclinical studies, we can extract the plant
Yes,
from the
ma'am.
plants,
Yes.
and then we can. Do you think it is proper? Can we actually convert this?
Certainly,
In
madam. Certainly. Madam, right now I'm working on ashwagandha, antioxidant and anti-inflammatory property, right? And I find that it's working well. We have conducted a study in horse. We have conducted a study in dog and cat. And when it came to horses, we found that not only in horses, in all other animals also, we found that it acts as a it increases erythropoiesis. It increases RBC production. So the same thing, it can be applied to diabetic patients also, where where the erythropoietin production is decreased. So can we use ashwagandha? Of course, it's only a hypothesis. I did not test in diabetics, but can we do that? Can we do that? Can we think of trying ashwagandha for increasing RBC production in case of diabetics? So, madam, as far as arthritis and other things are concerned, yes, if not today, tomorrow we may come out with a molecule. For example, artemisinin, right? When we were thinking that nothing would work for malaria, then suddenly this particular thing crops up, and then we say that it works well. So also ashwagandha, yes, as on today, that's what I'm working with, and it is showing a promising result. Of course, any researcher would say that his molecule is fine and fantastic. But one thing is for sure, even I'm using ashwagandha. There are other people also who are using ashwagandha. Ma'am, try ashwagandha, because in case of madam, in case of rheumatoid arthritis, if it is autoimmune, please don't use ashwagandha. But but if it is normal arthritis, you can certainly go for ashwagandha, because it
I
is
think the
antioxidant.
Himalayan drugs they have some capsules.
Yes,
Of
madam.
ashwagandha.
Yes,
I think,
madam. Yes, madam.
they have
And
been marketed.
scientific validation is a must, madam. Scientific
Yes.
validation and what a lot of work need to be done on this particular aspect, and see, okay, if it works, it works. If it doesn't work, let us say that it doesn't work.
May I add?
Yes,
As Dr. Sharmila said, phytochemistry is another new era of our pharmacology. Now, as you know, we have a heritage of all these compounds.
Yes.
The only thing is we have to extract it out.
Yes.
And in other words, we may refine it and develop it in a way that we can use it in human beings.
Yes.
And as all the authorities said, animals should not be used. Now this phytochemistry and in vitro exercises to find out the active principle and genetic, they will definitely add on these use of all these. And as our Prime Minister also said, there must be a holistic approach to treat any disease. So definitely all these plants, Ayush will play definitely an important role in pharmacology in near future.
Yeah.
So
long back in IICT, they conducted one study on hepatoprotective activity, and there it was about 30 years back, madam, 30 years back. But there they subjected this phytochemical as if it is a pure chemical compound, means they have gone for all the biomarkers, and the study was really good. I think every phytochemical has to be dealt as if it is a pure chemical.
Oh, but there are, we know that they are the mixture of so many active compounds. So
Yes,
that
madam,
we
yes.
have to extract it out, whatever we require, like that.
Yeah.
Because we never know at what compound will ultimately lead
Yeah.
to some sort of side effect or adverse effects, means short or in due course of time.
Yes, correct. What you said is right. Yeah.
Definitely.
Ma'am, there could be many compounds, but still a polyherbal compound or whatever it is, it has to be studied as if it has to be scientifically validated like a chemical compound.
Exactly. So anyway, we have to work hard to go through
Yes,
all these, to extract out and get the important one and then to be used.
Our labs need to be GLP labs, madam. I think that would be good, because if you want to retrieve the data or if you want to scrutinize the data, there should be a provision so that if there is a statement, the statement is backed by sound experimental data.
Definitely, sir. Definitely in near future is that only. So that
Yes, madam. Yes. So many of my friends, they're targeting US.
Yeah,
they don't want to sell their products in India.
Because a translational therapy or translational medicine is a upcoming, or I must say there's a new era.
Yes,
Definitely. Thank you.
Madam.
Thank you very much, sir, for the nice talk.
Thank you, madam. Thank you very much.
Over to Dr. Shambo.
Thank you once again, madam, and thank you, Dr. Kalakumar, sir. So I think one of the very major issue, whatever raised by Professor Kalakumar, Professor Ambwani, Dr. Nath, and also initially by Professor Mondal, was we need to relook into this animal experimentation, especially by the medical pharmacologist who are the PG students now are viewing us. I think this is one of the very important message. Though we are now talking about lots of alternative to animal experimentation, but at the same time we need to have a basic knowledge about this animal experimentation, which is required. And I think very recently, 2 years back, we had faced something which will be a memorable thing, not a good memory, but at the same time that will be remain in our memory for maybe 200, 300, 400 years. So at that pandemic time also, India had developed its own indigenous medicine, and at the cost of many animal experimentation, detailed animal experimentation, we know from rat to mice to monkeys, hamsters and monkeys, how they collect the monkeys. That is again become a very interesting story. So we need to emphasize on this animal experimentation. There is no doubt in that, and we need to know about these basics. And yes, the clinical pharmacology, other safety pharmacology, toxicity pharmacology, these all are important branch of pharmacology. But at the same time, this animal experimentation pharmacology should remain in our curriculum, and we should be nurtured with this topic of animal experimentation pharmacology. So thank you once again, Professor Kalakumar, sir, for
thank you
giving us this brief overview. One thing you had mentioned regarding this ashwagandha and its effect on erythropoietin. This is something which is very much encouraging for us also. See, we talk now about, when we talk manage diabetes, we are talking about therapeutic parsimony. How we can achieve that therapeutic parsimony. Just like if we use one drug that can address multiple issues. So if we get this type of molecules, this type of herbal molecules, as there will be no clinical trial available in the beginning, if we can use those herbal molecules, phytopharmaceuticals, through the magnifying glass of this animal experimentation, we can find some evidences on safety and efficacy there. And then we can plan for the clinical trials.
I
think that could be.
I'll share the data. Right now we are doing it on dogs, and also we are repeating the study in horses. And as far as horses is concerned, we are looking at the endurance. the endurance part of ashwagandha in horses. There we are looking at colony stimulating factor, a granulocyte macrophage colony stimulating factor, the erythropoietin, and all others that are involved in erythropoiesis. So I think that should, if it is going to be as per our hypothesis, I think that should be chance finding for diabetics.
Okay, thank you, sir. Thank you.
Thank you. Thank you.
So, just I want, I request Professor Tapan Mondal, sir, to say a couple of words.
Thank you, Dr. Shambo. Thank you, Professor B. Kalakumar, for your nice
Thank you, sir. Thank you.
regarding different models for your inflammation and pain in animal system. Now, in this context, I want to say that you are repeatedly telling that the animal experiment should be introduced in medical pharmacology curriculum, starting from undergraduate, postgraduate, and also PhD program. So one symposium or one seminar, one-day seminar was also organized by your leadership at Kolkata. And we have discussed in details about this. Particularly, one discussion was there, and the speaker was Professor Santanu Tripathi. He narrated nicely the different syllabus of pharmacology in medical, veterinary, and also pharmacy. And he showed that there is the involvement of laboratory animal experiment first in veterinary science, and then to some extent pharmacy, and no experiment in medical pharmacology. But it is necessary. Yes. Why it is necessary? Not forcefully. It is necessary in this way that, suppose in case of a graduate of any profession, and he is studying pharmacology. In most of the cases, I have seen that the students are afraid of pharmacology subject. Now, in case of undergraduate level, if we can see, if we can show some experiments, that what is the effect of the drug, particularly in case of your cholinergic and cholinergic drug, cholinolytic. So atropine, cholinolytic drugs, and your cholinergic, your pilocarpine, physostigmine. So if this experiment is demonstrated at the undergraduate level on a rabbit model, so they can realize, so I am giving the drug and there is dilatation of the eyeball in case of atropine, and if we give your physostigmine, so there will be constriction of the eyeball. So interest will be grown. So this is very important, as well as how the drugs will act for producing mydriasis as well as meiosis. So this is very important. So there are some experiments we can conduct at the undergraduate level also. Apart from this, in case of your postgraduate level, whenever we are going to teach the student, particularly central nervous system, what is the difference between tranquilizer and sedative? So this is the most important factor or point is that in case of your sedative, they will block the condition avoidance response as well as escape response. Whereas in case of tranquilizer, it will also only block the condition avoidance response. So that is theoretically we are telling. But whatever you are telling also, what is the CAR? So if we can show in animal model to the PGT, so it will be more helpful to the PG student. So therefore, I think, so this animal experiments should be introduced in the medical curriculum. And today's program is very, very helpful for all the PGT, I think. And these are the models which are very important, particularly in case of your drug development also, as well as the PG and PhD students. So with this few words, I am really thankful to our Professor B. Kalakumar on behalf of Indian Pharmacological Society, West Bengal branch. Thank you all.
Thank you. Thank you.
Thank you, sir. Thank you very much.
Thank you.
Every good things need to be ended at some point of time. So really, we are thankful to Professor Kalakumar sir, Professor Sneha Ambwani madam, Professor Tapon Mondal sir and Dr. Sharmila Nath madam for giving us their valuable time. And I think many postgraduate students were there with us. Almost 50 participants are still live as per the record. So we are really thankful to all the delegates who are present today. One thing is important now, as Professor Tapan Mondal sir was mentioning, if we do animal experimentation and show that to our undergraduate students also, that may make them more interested. You know, now everything is written in the book. The theory class attendance is less, and they can read from various sources. But this type of animal experimentations, if we can show them directly, that can increase their interest level. Just you think about the clinics in medicine. When we attend the medicine theory class, that is much less compared to the when we attend the case discussions, clinics in medicine. So similarly, if we have this type of training session more and more and live experiments, and after that we can make them understood the very essence of pharmacological science. So I think that will make them more interested. And mostly, as we are handling the animal, with this age, we also can learn another age, that is human. So more compassion we can learn when we are handling our animals. So that is also very important for our medical students too. So again, once again, I thank you all for being with us, and we are hoping to again having another postgraduate training module on 12th of December, where we will learn about the principles of HPLC, and Professor Shomir Malhotra, a head at PGI Chandigarh, clinical pharmacology department. So sir will take that session. We'll let you know about the details of that particular session later.
Yeah, you please include our PG students also.
Yes, definitely.
They would be
I will share the link, sir, with all.
Yeah.
Everyone can join
Please,
that. I
please,
think that will be a very important and interesting class too.
Yeah.
And we are all hopeful to join our IPS national conference.
Yeah. Thank you.
Coming in the 14th of December in Chennai. So we'll surely meet Professor Kalakumar sir there. So thank you once again. Thank you all.
Thank you. Thank you, Dr. Shambo. Thank you.
Thank you.
Thank you very much.
Thank you, sir.
Thank you so much,
Thank you
everyone.
all.
Thank you so much.
Thank you,
so
thank you.
much
Thank
for
you,
giving us
Shreyasi.
the opportunity. Yeah, thank you, sir. Thank you so much. Hope to have you again on our platform very soon.
Sure. Thank you.
Thank you, sir. Thank you.
Thank you, Shambo.
Thank you, sir.